Welcome an institution in hospital planning and designing, Dr. R. Chandrashekhar, Chairman of IGBC Green Healthcare Rating. Let's welcome our keynote speaker, Dr. R. Chandrashekhar, with a huge round of applause. Come on, everyone, can we have a big round of applause for him?
Good morning, everyone. I said, good morning, everyone.
Good morning.
This is the first session. The energy level has to be high. Okay. So today, I really thank the initiative by our Afzal Kamal and Manish. And of course, I've been connected with them for a quite long time. And also as an opportunity to again come to all of you and being a chairperson of the Indian Green Building Council Healthcare. And hello, and the green is a mantra nowadays, and to save the planet for our future generation. But we have also been supported to become green during COVID. Whatever natural, we were abusing nature, you could have seen Delhi's air quality came down to almost 50. Jamuna river, we could see 10 feet below even the pebbles, even the Ganga. The reason is that time lockdown, nobody was allowed outside and things were happening. That means whatever we are doing, it is we who are making it possible or spoiling it, whichever way you can call it. Also during that time, we were also talking about air quality. Lot of people got into the, air purifier, etc. You know the Delhi condition. Then I always used to say as an air quality expert also that you may use your air purifier, but for making it effective, you have to shut down the windows and doors. And when these are shut down, your CO2 level increases because people are all working from home. So everybody is at home. So these situations are to be approached comprehensively. So to start with, I'll say, what is the green hospital? Green hospital, who is the in center, is the patient, and supported by facilitator, that is doctors, nurse and staff. Then infrastructure, that is hospital building, including all department, lab, services, etc. Then the environment, indoor environment quality. I have already mentioned evidence-based design. Evidence-based design is that you are connecting with nature so that nature is a great healer. I'll also demonstrate during the presentation how that helps. And then some of the concerns of the green hospital is patient care and recovery, energy consumption, safe and desirable environment for healthcare professionals and workers, infection control, that is indoor air and environmental quality, light and ventilation, and waste management. Now, categorization of COVID hospital. When COVID emerged, Government of India started with the 3 levels because there was a case of asymptomatic. So therefore COVID hospital are meant for managing only COVID positive tested patient. And first level was this hospital will provide care for symptomatic COVID patient not requiring oxygen or mechanical ventilation and are having only mild illness, that is general ward with a quarantine facility. Then the second level where we had support of oxygen, which everybody has seen during that time what has happened and how to get an oxygen concentrator or whether it is an oxygen cylinder. That is how Government of India came up with a final version of every medical college to have a oxygen generation plant. And the third level was the hospital who can provide both intensive care and care those nearing only supplemental oxygen, that is non-ICU area. That means all the 3 categories are possible, and this is how the categories were, that one with a asymptomatic, and second was with needing oxygen, and the third needing the ICU facility. Conversion of operational hospital into makeshift COVID-19. This was another challenge because we were not actually prepared. And that is why nowadays in the Greenfield Hospital, what we are telling, have a larger span and have a drywall partition, the flexibility or adaptability or convertibility becomes much easier and faster. So here, creating a patient biocontainment unit with a separate entrance in the emergency department, then disinfectant chamber through which staff and patient need to pass through before coming and going from the premises. If you remember, there was a lot of pressure, and in fact, Planning Commission has invited me because there were certain agencies who are interested in setting up, helping in setting up ICUs at every district, because our challenge was to have an ICU facility, and creating a negative pressurized isolation room and treating exhaust air before leaving into atmosphere. One is, in Delhi, the air itself is, outside air was also bad. So first you treat it, use it, again before throwing, you have to treat it. Recently I am involved in one very special project which is called CBRN facility. CBRN means chemical, biological, radiological or nuclear disaster happens, how you decontaminate the patient, and bringing, after that only you can put him into the casualty or any other mode of treatment. In these, your ventilation methodology is very important. And similarly, this is the first of its kind of facility which is being built for civilian. Generally it is happened for, it is handled by defense. And also, we are also setting up secondary level of CBRN facility, that is towards our nuclear establishment, because we have seen in Japan when there was a leakage, or similarly, if we have seen the chemical bomb in Syria. So these are the kind of terrorist activities are happening. So that is the way. And here also, people have to understand the negative pressurization. During COVID, people wanted a negative pressure operation theatre. Suddenly to change over was a challenge. Nowadays what we do, we keep the last theatre, the end of that, with an anti-room facility with a negative, and today the HVAC with the guideline of ASHRAE and also our IGBC, you have the liberty to switch over the pressurization also. The technologies are coming. And then trapping and killing the bacteria and viruses by magnetic filterless technology, both in the fresh air and recirculatory air within the premises. Up till now, we were only trapping by filtration, but we were not killing the pathogen. So that was also become a need. You must have seen during the pandemic, lot of discussions were happening between the virus being airborne or not airborne, or maybe only moving towards up to 1.2 meter or 1.5 meter level. Is it heavy? There are so many things were happening and you all were aware. And finally, they declared, yes, it is airborne. And making necessary changes in centralized and standalone cooling system to incorporate bypass system to create negative pressurized and fan filter exhaust system. Some people also tell me, during when I was in charge for making the guideline for the COVID emergency system, that time they were saying, sir, you make all the air conditioning system for main AIIMS-like institution or big medical colleges. I run a clinic in a small garage or a small residential thing using, cassette type or split type AC. So he said, yes, we have to develop an introduction of ultraviolet there also, how we could bring in. So these were few things where we were needing it, and implication of ultraviolet germicidal irradiation or upper room UVGI in isolation, ICU and OTs. You know that ultraviolet directly coming in is always a harmful to your skin or your eyes. So how you have to make a upper UVGI. During that time you have seen the telemedicine. First initially our NIC has done it, nowadays even eSanjeevani. This telemedicine based EOPD, you can consult your doctor and without going to hospital. COVID has taught many more things. Why everyone should crowd around to this thing? You can always have this consultation. You have seen over a period of time, any amount of infrastructure you make, it is always in short supply. And what you need more is also manpower. So keeping that in mind, what is the best bridging method is the technology. Technology can only bring you a little common this thing, and EOPD and today also e-Sanjeevani etc., which is all happening, and also the expert opinion for the specialist consultation were also possible. That means you were trying to bridge the expert availability through the technology. So this is all, and let me tell you, COVID has brought our national digital mission, which Prime Minister was working on it. It's almost brought a decade earlier. It wouldn't have happened another 10 years if the COVID would have been there. Today, even a sweeper or anybody, you can give him a digital payment. So importance of IT was much more realized. And then we realized that, and today everyone has a smartphone. Don't think that he will not be able to understand or anything. Every patient, every person is able to handle it. Now, telemedicine kiosks were set up in various tier 2, tier 3 cities, where you could see each of the health spot is as a walk-in kiosk, contains high definition video conferencing system that allows doctor to discuss symptoms with patient, diagnose condition and prescribe medication. And the kiosk also have several digital medical devices. I remember long back when I was traveling to Uttarakhand and I was talking on telephone, and suddenly I found the driver stopped. I said, he said, sir, aap baat kar lo. After I finished, I said, why did you stop? He said, after this place, you will not get network. So our scenario of networking or the infrastructure for that was so poor. I was fortunate because I was being a chief architect in the Government of India, Ministry of Health. I interacted on the Planning Commission. I said, sir, we may come and talk in conference that this is telemedicine, this is the way you can go ahead. And when I go to the remote area or districts and I find downloading, connecting, etc., these are the kind of a thing happening. So we have to put, and if you remember the satellite launched and the gigabytes and how the improvement today everywhere, and that I have utilized when work from home. That time I was in Uttarakhand during COVID time, but I could do all my activity because of connectivity. So connectivity has become a big issue. So these, I may talk that yes, tier 2, tier 3 city, you can have this teleconsultation, but when network has to be there. Then crowd management. See, in AIMS, we have almost 10 to 12,000 people footfall per day. Even I was just discussing with our friends and colleagues here earlier that flooring, what kind of a flooring we require or how they handle this crowd. I was discussing this with our ministry, and our IT body is the National Informatics Center. They are the person who supports in Government of India. I said, people are fed up. Why can't we have an online appointment? Why can't we take an appointment as it is happening in the private hospital? No, it is such a massive thing, it will not happen. With a very great effort, they started with first attempt that like our railways and airways, just pick up one token, you sit, wait for your turn and OPD doctor will call. There were 5,000 people fighting in the token counter. I said, this will not work. You have to open a call center 24/7 and let the person take appointment. If a person is finished with his total number of guests, he is not giving it to him Wednesday, it will be Thursday, at least the person is not coming and crowding around. Hats off to our government doctor. That those people who are registered, they don't even eat their lunch and make sure that every OPD patient is attended. That is also a dedication of our doctors. But why can't we make a system and make it more this thing? So we made arrangement. Then AIMS JP Trauma Center. There was one neurosurgeon doctor was also more IT savvy. So he started that why not we do one thing, we issue a tab to all our doctors. And the moment the patient comes, he takes a picture. After that, doctors are not very comfortable with typing. So you can write it in tab. Bad handwriting may give medication error. So drop menu. And one more thing which we found, invariably people will come and then say, Sab, parchi gum ho gayi. After 3 months, the patient comes, and what doctor needs is a history of the patient. So this was very effective. You might be seeing now all the AIMS, RML, Safdarjung or any hospital today, everyone has to take appointment. There can be 10 to 15% gate crashes, but otherwise everyone goes with this appointment. Meanwhile, some of the private institutions also started using robo. You know, when touch and other parameters were also a cause of concern. So they started doing the work. Today, number of places, I was very happy. Nowadays you travel by air and with your mobile, your boarding pass and scanning, you don't have to. That means step by step we have gone ahead, and this kind of a self-service hospital, this was seen only in the private institution earlier. Now it is being used everywhere. I need to reduce manpower and use the technology so that it can be working efficiently. You can have the mobile point of care, that medical computer card. So it will be mobile workstation for electronic patient record and clinical viewing. Then mobile clinical assistant near the nursing station, and also bedside infotainment. Why? It is information and entertainment together. A person has come and admitted for knee replacement, but he can still work for his office because of the connectivity. So he has the information also and entertainment also. And going mobile at the point of care, nurses spend 90% of working time traveling between nursing station and patient ward. A highly integrated computerized nursing card to optimize patient care process and enable mobile point of care. We have in government setup very great shortage of nurse. You know that in a private institution you can engage a nurse and that will be actually paid by the patient. Here the patient care is free. I being from government, my concern is how I can help them and get the efficient care of delivery. So one nurse with all these parameters. This is first introduced in when we started, it was in Tata. Then we brought in to our Safdarjung hospital. Yes, this is very nice. I'm talking way back. He said, but we don't have a Wi-Fi system. Oh, it doesn't work without a Wi-Fi. That time government make a mandatory requirement that everybody should have a Wi-Fi. Because now today the scenario is wherever you go, connectivity is not an issue. You must have seen a lot of people getting to claustrophobic effect. I cannot get inside, particularly children, elderly people. So this is the kind of an MRI which came into this thing. You could see the first picture where you can see a pediatric child feels, and it is also being taken care in a way that mother is, I remember long back, I am talking about 90s, when I was in Singapore, I went to a X-ray, this thing, it was a pediatric. Now you can find it in a lot of our private institutions. The entire wall was painted with with a McDonald, the Donald Duck and this thing, and there is a park. So child feels as though he's coming into a park and he's been pictured. That is the kind of a psychology. Now today you are finding it in India in every place, including an operation theater gets a ceiling with the interest or even the walls. They don't have to be all the time. So those technologies have come in. So this is also one, and then bariatric, the larger size patient has a limitation. Similarly, the geriatric, that is the elderly people, and also the claustrophobic effect, he doesn't find, oh, I'm getting into the tunnel, I don't want to get in. You must have witnessed all these things. So these are the latest in MRIs also come. So this is how it looks like. And social distancing was one which was vouched everywhere. You could see, even in the village hospital, people have followed that because that was the severity needed. Then impact of emerging technology in hospital post-COVID. What all will be started happening? One, the pharmaceutical will replace some procedure and will decrease the need of admission to hospital, and newer vaccines will treat as well as prevent disease. Recently, I just saw how far, I haven't verified that, but they have come up with a vaccine for the cancer also. This is cervical cancer. That is what recently I had seen it in the news item. But of course, verification needs, because today we have a great university called WhatsApp University. It circulates number of things which are, not 100% verified, but sometimes. And with that, media started one more channel called what is that? Fake news or some viral search. Means what is viral happening is whether it is truth or it is a fake news. Then minimal invasive surgery, which is already in position, will reduce hospital stay and promote outpatient operation. And robotic surgery is already in place. And sensors will change central laboratories and intensive care units of the day. Then in a digital hospital, systems and people can communicate with each other to make the hospital more responsive, agile and flexible. As you are aware that digitization has been very strongly promoted by the government, and up-to-date information improves responsiveness and eases the information bottleneck that block hospital throughput. Two-way communication between nurse and patient reduces unnecessary walking by nurse, giving them more time to focus on patient care. When the nurse call system came in, prior to that it used to be, first you press the bell, the person will come and he'll check what you want, then he'll go report. So now everything has been streamlined. Like in our offices also, what we used to have, first you press a bell, peon will come, you'll say call so and so, then he will come and then you will delegate the call. Today you pick up an intercom and tell him, please do the needful. So that is how the time has been changing. And you know that India, in a digital India, matchstick, in digital India, which is Government of India's greater initiative, National Digital Health Mission, which was launched in 15th August 2021, and we have a Health Authority of India, and they came up with lot of things. There is a complete document available. Then we came up with the PMAB. It is Prime Minister's Ayushman Bharat Health Infrastructure Mission. This was the lately, launched. Why? This was the reason. They found what was the drawback during the COVID diagnostic system. Our lab system was a big problem. Second was the ICU facility. How to integrate all the laboratory in the district. See, when I am now addressing, I am not addressing, focusing to our metros. Metros can have number of facilities. My concern is to tier 2, tier 3 cities and also to the district. And a network of wellness center was introduced, because why everybody should get into the hospital when the basics are met within his own district. So these are the things. I am also a consultant to Indo-UK Institute of Health, where the main idea is that setting up 1,000-bedded hospital in 10 or 11 places, but around 76 small screening centers, so that a person can get into a basics, like he has certain lab test or ECG or something is done and he has been treated there. Why he should come and rush around in the hospital? Why all this? If infrastructure is big, the cost is going to be more and the manpower involved is also more. Imagine if you are having number of computer station where OPD patients are taken into this thing, that many station, one queue may handle say 60 or 70 patient with the available OPD time. That means how many number of station and how many people and in shift how you are going to handle. If I am giving everything online, only the limited people are coming, so that means I am squeezing the square foot area of the infrastructure. That means my cost reduction and also my maintenance cost is also reduced. See, we anytime always going for a capital cost and a recurring cost. So this is how, and then lately, Prime Minister's DHM, that is Digital Health Card, you must have all read in the news, will create a seamless online platform through provision of wide range of data, information and infrastructure service interoperability. Long back, I had conducted one conference called ICMA, International Conference on Medical Architecture. That time, actually, I was doing my fellowship in London. So when I came back, I remembered my digital card at that time. I'm talking about 90s. That card was my ID, and also I can there, for even taking photocopy or any activity you have to pay. And that card will, you put it and that will deduct like your smart card as on today. I said, when we are making this kind of a delegate path, why can't I create a card and let the vital statistics be there, like what is his in emergency, whom to contact, his blood group, etc. You won't believe, when we started doing, they said in the form we have given them to fill up, but everybody didn't do, we set up a lab also. 40% of our delegate turned out to be diabetic. They never knew. Arey, sugar, itna hai. Then my other attempt was that card, next step, you can make it a smart card. This is how I was thinking in 90s. And also when I started doing it in my own aims, I said, you introduce this card. What happens? The doctor tells you, go and get this checkup done. कहाँ 19 नंबर में जाओ. 19 नंबर वाला बोलता है पहले काउंटर नंबर 10 में पैसा जमा करके आओ. Then show me the receipt. So these hassles were all out when you deposit some money and how you can do. What you are all doing in a private sector, but when it comes to the larger volume, this was being handled here. These were the severity of disease versus resource requirement was critical, we need a mechanical ventilation. Severe, we needed oxygen therapy, and moderate isolation and normal one. These were the things. Emergency department, create a robust one-way triage flow for the hospital emergency department. Create a referral screening pre-triage unit in front of and adjacent to the emergency department. This is how it happened during the COVID, because we had a set emergency. So we wanted, before the fellow enters, he's been scanned. I'm just demonstrating that in every district they wanted a separate infectious disease ward. COVID has come and gone, some other thing may come in. So if you see the circulation, these were the separate block made in which we were having an entry for the doctors and nurses and their staff. From the entrance, you have one side a lab and a pharmacy, and other side the doctor and nurses room, where they change and get into a semi-sterile clear corridor. You know that donning and doffing area. So this is donning area where they change their, this thing and get into the EP kit, and then they get into the sterile corridor, then to the area of where the patient room is there. From patient room, again the return track, where doffing area, where they dispose of their clothes, and then come back to this. And this ramp and separate entry for the patient to directly get into the room, and also the patient, if it is dead body, is to be taken out. and it had the dirty room and the clean room, also the space for AC plant room, so that it can happen independently. Because COVID, initially government decided let us have a COVID hospital separately, but you never know when and a patient comes into this. So district has decided that why not have a COVID block or a infection. They didn't call it COVID block, they call it infectious disease block. This is just in the same thing in a 3D form, that how from the main area they get into the change area, and from change area they get into the relatives area, patient room, and then from patient room again how they come back. So this is just to shower and come back. This is just to demonstrate this. Then advanced design concepts were also developed during the COVID time. If you see the black arrow which you are seeing, that is the patient entry. And the green is the staff used to enter through that, but through red with that biohazard and then dressing room, they used to come out. Because that kind of a fear thing was there. And infectious disease, these are the standard protocol how you have to follow it. And isolation room, as you are aware already, that you have an access and an isolation room with a negative pressure, and wherever the pressurization is also very, that is also there. And this is the kind of a COVID ward which we developed, in which was based on an evidence-based design principle, where every individual can see it outside and also can feel, connecting with nature. And here, the two rows, you can always see that it can be a male ward, male or female, or if it is a super specialty, you can have a neurosurgery one side, neurology one side, cardiosurgery one side, cardiology. I can't afford a single room for all my patients in a government kind of a setup. So this, you are getting the feel, and also being a teaching hospital, you can have those other facilities added. Open courtyards are there, and you have a cross ventilation, or even if you want to have a air condition, that is also possible. Still closer view, you could see a central wall will give you the sharing of these services. The view will be looking like this. This is how you can have an independent one, create an infection control parameter, airborne infection, at the same time you have, and also the air conditioning system also get into a very specialized. Selecting finishes and furniture is very important. We have learned that your system should be cleanable, material withstand repeated cleaning, easy to maintain and repair, durable, resistant to microbial growth, that is metal, acrylic, mineral, copper in all touch surfaces, non-porous, because porosity or joint lead to infection, seamless it should be. So these are a few parameters which you should keep in mind. And pre-engineered building, performance-based, will be preferred construction technology because you can quickly erect it. This WHO came up with the severe acute respiratory infection, that is SARI treatment center, in which they have given a guideline that minimum requirement for converting existing building into SARI treatment center, an existing building may be repurposed into SARI treatment center if the minimum requirements are met. What are the minimum? Minimum ventilation rate of 60 liters per second per patient for mid and moderate wards. Minimum ventilation rate of 160 liters per second per patient for severe ward and intensive care unit, and airflow from clean to dirty zone, and patient and staff flow can be clearly defined and distances respected. All finishes, furniture and patient care equipment can be effectively cleaned and are compatible with the facility's disinfectants. This is how the layout was, where I was telling you about 3 levels, like which I had explained to you. The first level, I think your thing is not working. Anyway, the first level, second level and third level. First level was where you have a patient waiting and triage. From there you get into short stay, severe case and the critical cases. and the central portion was the staff, which they can move independently. And these were all divided with the proper airflow zone. And for that, if you want to know more detail, you can see and refer our IGBC guideline. This is available free of cost at www.igbc.in, where we have the guideline for fast track and emergency facility for treating COVID-19 patient, which can have all the air conditioning system. Where you have a good cross ventilation, you can have a cross ventilation. Where you have a ventilation system with a forced mechanical, you can do that. There is a hybrid system where you can have a forced mechanical, but the outside air is quite hot. Then in that case, you can add some cooling inside. And third is a normal air handling unit type of system. Remember, 80% of the infection used to happen through touch surface. Copper, use of copper is antimicrobial. You can use like door handle, grab bar, IV fluid stand, or this thing. You can see wherever you are going to touch, that can be a copper. And you can see the copper surface installed in intensive care rooms fitted with copper components over the patient table, IV pole, monitor pen, bed lever, visitor chair, even the stethoscope where it is maximum in use, and also technological method which I just explained to you. First was pressurization, which is negative pressure in isolation room with respect to surrounding, and similarly dilution was the second, which was for high ventilation rate, that is air changes per hour, control particle by removal through ventilation, and filtration, that is use of pre-filter, microwave filter and HEPA filter. We were stopping there, but now we have to introduce purification. That is what I explained to you, the use of UV radiation, that is ultraviolet germicidal irradiation, or PHI is the photohydroionization, or HEPA MD. HEPA is high efficiency particulate arrestant, but MD is microbial destruction. So that was the addition. Then airborne infection isolation refers to isolation of patient infected with organisms spread through airborne droplets like COVID patient, TB, chickenpox, etc. And protective environment, that is, suppose there is a person who has undergone a stem cell or bone marrow, these people are the one who needs a kind of a protective, because their immunity is much lower. And these are the negative pressure isolation room parameters. That toilet ward requires around minus 20 Pascal and 12 times the ventilation frequency of 12 times per hour. And similarly, patient corridor minus 10 Pascals with 6 times, and buffer room minus 10 Pascal with 6 times. Similarly, the treatment room and the medical staff corridor and medical staff office design with a minus 5 Pascal. So these are all available in ASHRAE guidelines also. And UVGI, where to use it? So you can use it on coil or in duct. So this is where you were able to control. These are the known technology and recommended by CDC, Central Disease Control of Atlanta, and ASHRAE too. So these are the kind of a thing. Then I explained to you, people were asking, I don't have a big establishment, how to handle it? So we have designed for all aircon system, whether it is an old or new air conditioner, central air cleaner is the suitable for all type of HVAC system, such as air handling unit, fan coil unit, ductable, TFA, HRV cassette, split AC, all. And the system fulfill your specific need. So you can have it on split AC, ductable fan coil unit, even in the cassette AC. And this is how the test results which we have worked out. Virus kill rate was almost 99%, the SARS, COVID, etc. Then bacteria kill rate, like microorganism, that is all 100% to 70%. PM 2.5 reduction, that particle, the PM10, PM 1.0 is 90% and 2.5 is 95% efficiency. And volatile organic compound reduction, that is gases, etc., that is also 90% efficiency. This is how the system works. where the air is pushed in and it is trap and kill technology. That means you are not just trapping the pathogen, because in filtration it will be colony of pathogen. And these are the three stages. First stage, pre-filter. Second stage, polarization. And third stage is agglomeration. So you will be finding that the effective of PM 1.0 is the first one. Whatever escapes, it becomes the microparticle. The second stage, and the third one, even when these are all the polarization, the dual polarity, no arcing, trap and kill, kills the germ. So it is effective. So this is how. Then HPIE MD. What is HPIE MD? This has 4 stages. First one is exposition to non-thermal plasma. Second is captured by electrical media. Third is molecular filtration. And fourth is molecular trapping. In the first one, we have a microbial destruction. And in the second one, biological decontamination and high efficiency particulate arrestance. Whatever escapes from here is the catalytic conversion, and the final one is molecular trapping. So in all, you are 100% sure, because this is available in this kind of a model. Sometime you have a room, you can use the first one, that mobile air decontamination. Just keep it like a cupboard in any of the room. It will do the needful, like your air purifier, but of course it is an advanced one. And sealing air decontamination unit. Then there is a mobile protective environment. Sometimes a burn patient, is very highly infectious. So you can control within that area. You don't have to make the whole system air conditioned to be effective. Sometimes it is not possible. So you can do that. And sealing diffuser system for air decontamination. So the benefit of the air disinfection technology: proven protection against transmission of airborne pathogen, proven benefit to the healthcare sector, effective against MRSA, norovirus, etc., and effective against unpleasant odor. And current CDC guidelines recommend negative pressure rooms with anterooms for patient with hemorrhagic fever and use of HEPA respiratory by person entering these rooms when the patient has prominent cough, vomiting, diarrhea, or hemorrhage. Face shield or goggles with help of prevent mucous membrane exposure to potentially aerosolize infectious material in this situation. These protocols we have drafted in the health ministry, that if I wear my gown and go inside, if the patient vomits in your gown, how you have to handle, what kind of eye protection you have to take it. So these were the few guidelines. And use of COVID robotics become popular during the COVID time. Nobody wants to go inside but want to have a disinfection. So high concentration of ultraviolet rays that destroy contagious disease, these can be used most effectively in the decontamination or detoxification of COVID healthcare facility. It is looking like this. It operates with your mobile phone or even your tab, and you push it in, and within no time it will disinfect the entire area. The striking robos were one which you can disinfect your toilet, your individual room, wards, etc. It takes hardly 10 minutes, and once a patient is discharged and again you want to sterile your room, it is possible. And micro solution like sanitizes almost 99.9%. Even your wheelchair, etc., also can be exposed to UV technology, and that is how the sterilization used to take place. So many thanks for all your attention. And anybody has any kind of a query, because here I don't know how much time they are going to have. Anyway, I'll take some question if required, but they can always email me and get this thing. Thank you. Any question?
Alright, so I would like to request Mr. Afzal sir, please come up on the stage to receive an honor, to give an honor to Dr. R. Chandrashekhar sir. Come on everyone, can we have a big round of applause for sir? for such an amazing presentation over here.
Go green.
Go green.